Good afternoon. My name is Beatriz Domínguez Gil. I'm the Director General of the Spanish ONT, Organización Nacional de Trasplantes, and it is my pleasure to welcome you all in this webinar, which is targeted to revise and share best practices in liver transplantation between two countries with an outstanding activity of liver transplantation, which is Italy and Spain. As the director of ONT, I have to say that we are particularly eager to learn from our Italian colleagues, where we have seen their outstanding evolution in terms of liver transplantation activities, with similarities with Spain, like, for example, the advanced age of our donors, but also with important challenges, like, for example, the 20-minute no-touch period that is applied in the DCD program in Italy according to their law. We also have a very important similarity, which is the use of NRP, normothermic regional perfusion, is the standard of practice in DCD activities in both countries. So as I said, similarities and some differences, and a great opportunity to learn from each other. I want to say thank you to, of course, to all speakers that will be introduced along the webinar. In the interest of time, I will not say the names right now. They will be introduced in due course. Thank you all for sharing your time and your knowledge with all participants. We are expecting a great number of participants to the webinar. So thanks to all of them for their interest in this initiative. And finally, I want to thank Giuseppe Feltrin from CNT Italy for his interest also in making this webinar happen. So Giuseppe, thank you very much for supporting this. And of course, I want to thank the Spanish Society of Liver Transplantation and its president, Magdalena Salcedo, for her determined support for making this webinar happen. And last but not least, let me thank professionals at ONT, particularly Gloria de la Rosa, who has been pivotal for organizing this webinar, and of course, Amparo Luengo for her technical support to make this happen. So without further delay, I'm going to give the floor to Dr. Giuseppe Feltrin, Director of CNT Italy, and Magdalena Salcedo, President of the Spanish Society of Liver Transplantation, who are going to be co-chairing this session. So again, thank you, and the floor is yours.
Thank you very much. Good afternoon. It is for me a pleasure to be here and to collaborate with the ONT in this meeting. And I think it will be a lot of value to share our experience. I will introduce the Spanish speaker in the next speaker. Is Jordi Colmenero. He is a pathologist. No, sorry.
No.
Gloria. Gloria, sorry. Gloria de la Rosa is a medical doctor, is the leader of liver transplant in the National Organization of Liver Transplant, and is the coordinator of the studies in collaboration with our society. Giuseppe, can you introduce your colleague?
Yes, good morning, Magdalena. Good morning, Beatriz. Good morning to everybody. Thanks to Spain for inviting us to this very distinguished meeting. Of course, the wish is that this meeting will be very fruitful for everybody, and we are here to make this go in the best way. After Gloria, there will be Silvia Trapani speaking. Silvia Trapani speaking is a medical officer of the National Transplantation Center in Italy, and she is mainly involved in all the activities regarding liver transplantation and location. And you will see some details of our national activity through Silvia that I thank in advance. So I think, Magdalena, that we can start.
Okay.
Thank you.
Thank you very much. I'm going to share my presentation. Can you see my presentation?
Yes,
Gloria,
perfect.
proceed.
Yes, Gloria, and you can go. You are full screen.
Okay, so I am going to start. Welcome to this symposium, which aims to improve clinical practice in liver transplantation. I will present you the current scenario and the recent evolution of liver donation and transplantation in Spain, focusing on transplant activity, a waiting list indicator. Spain, with a population of 50 million inhabitants, has 26 liver transplant units, and for one for every 2 million inhabitants. This had made possible to perform 34,500 liver transplants in Spain during this period, since 1984. These units have extensive transplant experience. 16 have performed more than 1,000 transplants, and we have 4 hospitals that have carried out around 2,000 liver transplants in this period. We can observe, sorry, I have lost my presentation. Yes, we can observe here the continuous upward trend in liver activity, except for the COVID period. It is a sustained increase, as last year we achieved our highest liver transplant rate with 27.6 transplants per million inhabitants. This high and increasing activity in liver transplantation has placed us, together with Italy, at the global forefront of liver transplant activity. For this reason, we would like to thank our Italian colleagues for agreeing to compare with us and for sharing successful strategies in this field here today. Our transplant activity showed changes in the donor profile. Just 10 years ago, the vast majority of liver transplants were carried out using DBD donors. But in 2024, DCD donors have reached a similar proportion. Therefore, the incorporation and significant growth of DCD donation has allowed us to achieve this excellent liver transplant activity. However, we have a liver retrieval rate of 73.3%, and the percentage of grafts actually utilized barely exceed 50%. These indicators differ when we consider the 2 types of donations separately. In the case of DBD donation, livers are retrieved from 80% of donors and utilized in 62% of donors. However, when we focus in DCD donation, there is still room for improvement, as the liver is retrieved from 67.2% of donors and used in less than 50% of the donors. This has been accompanied by an evolution of the donor profile, as the proportion of donors over 80 years has been reduced from 1 to 1/3. Consistent with this incorporation of DCD donation, we have seen a decrease in a stroke as a cause of death from 70 to 53% of donors, while anoxis encephalopathy has increased. Despite high liver donation and transplant activity, a much concern for us is the high proportion of retrieved liver grafts that are ultimately not used, exceeding 30% in recent years. Last year alone, 567 livers were discarded, mostly due to macroscopic appearance, and the combination of high activity and short waiting list likely contributes to this elevated discarded rate. This graph shows a post-pandemic recovery with increases in new listing and transplants, but the waiting list still remains half due to hepatitis C treatments. Without expanded indication, transplant would have been surpassed new listing in 2024. In contrast with donors, we are increasing the age for recipients at transplant. Recipients over 70 years old now account for nearly 7% of the total transplant, and this is also one of the new expanded indications. The diagnoses are cirrhosis, accounts for more than a half of our patients on the waiting list, followed by carcinoma in 22% of our patients. Here we can clearly observe how the number of patients with indication related to hepatitis C virus has decreased from 32% a decade ago to barely 7% in the past year, which is a very good news for public health, but presents a challenge to waiting list performance. Our waiting list indicator shows our waiting list is managed very quickly, but also remains in a very delicate balance. Last year, the average daily number of patients on the waiting list was around 300. In the list, 72.5% of patients underwent transplantation. Mortality did not reach 2%, and 8% of patients were removed from the list. Therefore, there is a very high probability of transplantation, but within a small number of patients remaining on the waiting list. So this graph shows that the reduction of the waiting list has improved all of our indicators. The transplant probability in green color has increased, and consequently the number of deaths in red color, exclusions, yellow, or active patients in blue have decreased considerably, showing the positive impact of the reduction of the waiting list and the high transplant activity. This waiting list reduction, along with the increase in liver donation and transplantation, has allowed us to develop strategies to address the problem that the probability of children being transplanted were barely 37% 10 years ago. By prioritizing donors under 35 years old for the pediatric waiting list, the probabilities of transplantation are now most equal for children and adults, and around 70%. As a consequence, the waiting list time for both adults and children on the waiting list is under 40 days, which also demonstrates that we have successfully reduced the long waiting time that pediatric population in our country used to face. In Spain, not many split liver transplants are performed in our country, but the trend is significant and favorable. By assigning all donors under 35 years old to the pediatric waiting list, there was a boost in split transplantation, which has allowed us to substantially increase our activity in this type of transplant, which was previously almost non-existent. To conclude, I present here the expanded indications that have allowed us to maintain, although in a very delicate balance, the volume of the waiting list. These include age over 70, acute and chronic liver failure, hepatocarcinoma beyond Milan criteria, cholangiocarcinoma, and severe acute alcoholic hepatitis. All of these indications were incorporated by consensus of all teams and are based on criteria supported by scientific evidence. So with this expanded indication over the past 5 years, we have added near 600 patients to the waiting list with this expanded indication, which has boosted the waiting list, but given the high level of transplant activity, we believe it is still not enough. So we can see how the trend of the black line here, representing the new inclusions, has managed to break out of that decline and reverse the downward trend, thanks, although still in a very tight balance, to the incorporation of these new indications for liver transplantation we are going to see in detail after. So we have the diagnosis, high transplant activity driven by elevated donation rates thanks to DCT donation together with the cure of hepatitis C virus patients has led to a sustained reduction of the waiting list volume. Despite the incorporation of expanded indication, this has not been enough to reverse the trend. The scenario has therefore changed radically. The diagnosis is clear, but a new therapeutic strategy is needed. So thank you very much for your attention.
Thank you, Gloria and Magdalena. If you agree, we can move to the next speaker.
Yes.
Okay, so we can leave the floor to Silvia Trapani.
Thank you. Good afternoon to everybody. It's a pleasure for me share with you my presentation on liver transplantation activity and waiting list in Italy. I would like to start by showing you the donation activity in Italy over the last 30 years. These are the rate per million population of our actual donors. And as can be seen from this number, we have seen a steady increase over the course of our activity. In 2024, we recorded a 4% increase compared to 2023, a year in which there was a significant upward trend in the figures, and a further increase of at least 3% is expected in 2025. The following bar chart shows the numbers. Focusing on liver donation, the most part of our actual donors are liver donors. This is a figure that places Italy among the top countries in the world. Liver is used in 90% of organ donation and is the most used organ, followed by kidneys in 70%, heart in 20%, and lungs in 10%. Let me point on two figures. The first one is that only 10% of livers are discarded because they are really unsuitable. There is also a part of available livers not allocated on regional waiting list for different reasons, such as lack of recipient for risk rather than for blood group or size. This accounts for about 6% of the total available livers. But these don't get wasted by the nation because they are offered to the other regions and retained on the national territory. The second one is evident looking at this table, where you can notice what I highlighted in the following slide. The percentage of utilization of available livers has slightly increased over time, whereas we can't observe the same for kidneys activity, which decreased in the last years, probably due to the characteristics of our donors. A slight increase was observed in heart activity. To explain these great results, I necessarily have to speak about the solid collaboration between CNT and Liver Transplant Center. Every decision and every change follows a process of sharing the results of allocation and transplantation programs between the competent authority and transplant center. This, for example, made it possible to improve the national liver allocation system in 2019 with the introduction of the ISO score through a consensus process that began in 2015. The new system is based on the principle of balancing between urgency to guarantee the lowest waiting time on the entire country population and to sustain the large donation rates, while maintaining low cold ischemia time and choosing also the best donor-recipient match in order to ensure also the transplant benefits. Over the years, this has required continuous monitoring of results, control of the introduced changes, and real-time implementation of all the necessary corrective measures to bring the system back into balance. These are some examples of national programs we managed during the year. To maintain this objective, the CNT in July 2019 established the working group on liver allocation under its governance, composed by all the directors of the 22 Italian liver transplant centers, regional representatives, and scientific society. We organized many meetings during the year to address the difficulties that the centers report to CNT, and the CNT reports to the centers through data analysis. In this way, we have modified the split liver procedure criteria more than once after the introduction of the mandatory split liver policy. As we notice a decline in the number of procedures performed, we have revised the access to emergency programs, which over the years were no longer representatives of the type of diagnosis leading to transplantation. And similarly, we obtained full reimbursement for DAA for all the recipients on the waiting list and managed the new indication for liver transplantation, such as transplant oncology, which needed to be regulated. These results are certainly due also to the great ability of our liver transplant center to extract and use all the available resources, in particular the extended criteria donors, such as donor after cardiac death. This activity has started to grow slowly in 2015 and has reached rapidly high levels of activity. In 2024, the donation from DCD represented the 16% of the total donation activity. In 2025, it was expected that it achieved the 24% of the whole activity. Detailing on the liver, 91% of available liver from DCD is transplanted, the same percentage compared to DBD. In addition to what I mentioned before, as the bar chart shows, the use of DCDs over 70, despite adding more difficulties, has increased over time. In 2024, both in terms of the total number of donors used and liver donors specifically, they accounted for more than 40% of the total. HCV donors are another example of ECD and representing the last year a resource to expand the donor pool. We used 60% of available HCV donors over time, and liver transplant accounting for 40% of these, despite viruses located in livers. The pie chart shows you the percentage of utilization of the other organs and indicates us that we can still do a lot to implement the use of the heart and lungs. As I previously said, in August 2025, we obtained the full reimbursement for direct-acting antiviral, including for patients on the waiting list for other organs that in these years have a little exploited this kind of donors because of this critical issue. We therefore are expecting the percentage will increase in the next years. Going back to the donor age and to some extended characteristics of our donor, Professor Cilo will speak after me and talk about the recipient age in details, but let me focus rapidly on the body mass index that often resulted as a risk factor for liver transplant outcome, and the mean age of our donor. About 55% of our donor has a BMI higher than 25 and the mean age of 62 years, so a high medium age. Furthermore, as you can see from the slide, we registered an increase in the number of donors aged over 70 and over 75. An interesting fact, the oldest female donor age 100 was reported in Florence, and the oldest recipient was a 77-year-old female who received an organ from an 85-year-old female donor. These figures and this constant activity led us to achieve these significant results in Italy. Looking at the newsletter Transplant that refer to 2024, Italy has the highest rate of liver transplant per million population. And this is the total liver transplant activity from deceased donor, and the bar chart indicates an estimated plus of 1.5% increase in 2025. Focusing on DCD and HCD transplant, total transplant, they account respectively for 15% and 2% of total liver transplant activity. And we are expecting this percentage to increase further in the coming years. The final figures that I wish to highlight is the split liver procedure performed over the time. They represent the 6% of total activity, and as previously mentioned, we noticed an inflection, a decline of these in 2024, and introduced immediately a correction, expanding the mandatory split liver criteria. As a consequence, we notice an estimated increase of 10% in 2025 activity. Finally, the last data I show you is the flowchart of our liver transplant waiting list, which shows that in 2024, we had an intention to treat of 2,700 patients, 62% of whom received a liver transplant with a mean waiting time of 4 months. Mortality on the waiting list was 3%, with a total dropout rate of 5.3%. These two figures are big results for Italy because we registered in the last year an increase in the satisfaction of waiting list and a decrease in the total dropout. So take-home messages. The number of organ donors in Italy has steadily increased from 2018 to 2024 by 26%. The liver is the most used organ, 90% compared to 70% for kidneys. The liver allocation is based on the principle of equity and transparency and involves continuous monitoring and correction of imbalances at national and regional levels. The liver transplant activity recorded in 2024 was the highest in Europe, and this is due to the governance of the CNT that guides and collaborates with all the liver transplant centers, and to the high expertise of the Italian Liver Transplant Center in the utilization of all the available resources. Overall, 60% of patients on liver transplant waiting list are satisfied, and this percentage has increased in recent years, along with the reduction in waiting list dropout. And thank you for your attention.
Thank you very much, Silvia, and thank you very much, Gloria. Really, there are very interesting data, and the comparison is surprising because we share some condition of the epidemiology of the donors, but really the evolution of the donation is very, very different. So I would like to ask Beatriz if there is any question in the audience, please.
No, I cannot see any question. I would like Silvia to stop sharing her screen because we will see each other better. And I will beg the audience to use the preguntas section, the question section, to place there whatever comment you have for the speaker so we can formulate to them. And I'm seeing some coming.
In the meanwhile, can I make a question?
Of course, Jordi.
Yes, first of all, congratulations, because what I see for both is a story of success, no? It's like looking the results of Messi and Cristiano Ronaldo. I mean, I will not say who is who, but I mean the results of both systems, I think that are excellent. My question for Silvia Trapani is, do you think that as you increase the number of DCDs, obviously you will see a decrease in the DBD, and how do you think that this can impact in your split policy and in the number of patients of donors that can go to a split and be shared in for two different recipients? Do you think that is something that is going to happen, the low utilization for a split, and what do you expect on that? Because I know that you have a lot of experience on that. Thank you.
Jordi, just to complement that question, Silvia, could you specify what are the mandatory criteria for splitting livers? And then you can maybe address the question formulated by Jordi.
Yes, in the mandatory split liver policy we introduced in 2015, our criteria were a donor at standard risk, with no risk to transfer any disease, and under 50 years. Then we decided to expand this criteria, enlarge the donor risk. So now all the donors under 50 years and at any risk.
Thank you so much, Silvia. Just to elaborate a little this more, DCD livers evidently are not subject to split, just to clarify that, right?
If I can answer for my possibilities to the question of the colleague, I think we didn't introduce any particular policy. I think that the increase is due to a focusing of our liver transplant center on this activity, and on also on their ability to find a right donor match with the donor and recipient match. So I think this, but I think that Professor Cillo can answer better than me.
No, just if I may, just to simply improve this, is we are aiming to expand the 50-year cutoff with no limits, with particular reference to the oncologic indication. So we might use techniques like the rapid technique, which is an auxiliary transplantation, using splits above 50 years of age in order to increase the availability of organs for oncologic indication. So that is something that we are speaking and we are elaborating at the national level.
If I may add also, sorry, Gloria, then I'll leave you the floor. There's another thing which is important. At the moment, when we have a DCD donor, we are not using national policies for allocation. So the allocation is regional at the moment, which is something that we are doing from a strategic point of view in order to encourage the centers to do DCD donation. So the donors which is in a region is used by the transplant centers of the region. Okay, so of course in this way the centers have the best way to match the characteristic of the donors with their recipients, being free of algorithms or regulation that come when we have a DBD donor which goes under national policy. So for example, just to let you understand, we don't allocate DCD livers for national emergency, but of course a center regionally can make it. So I think this helps a lot to fit the best donor to the best recipient.
Okay, thank you.
Also
We have a question or a comment. Sorry, Giuseppe, sorry.
Sorry, Magdalena.
We have a comment from Gonzalo Crespo, the Clinic of Barcelona. He say that using 90% of donor is fascinating for him, versus 60 and 44% for us in Spain. Why would be an explanation? Maybe because the case that in Italy some livers are pre-discarded according to liver test, steatosis, or anyone test, while in Spain we go and see all the liver graft offered. The number of overall donors is higher in Spain, so that may be a reason. More use of more previously selected donors could be a reason. Really, the difference is
no, as I show you, the only 10% of our available livers are discarded because they are really unsuitable for steatosis or for cirrhosis or for other reasons. It can be possible that a regional doesn't allocate his liver on his regional waiting list, but these that livers have offered to the other region and retained in the territory. So very few livers are discarded in Italy.
Yeah. Yes.
Gloria, you wanted to ask anything? Because
Yes,
I have a question about the waiting list, but we will skip that for the second block. So Gloria, please go ahead.
Okay, my question was in the same sense, because I was very surprised about the high utilization rate. And I think one of the factors that modify the utilization rate is the waiting list volume. So we have registered a very strong impact of new hepatitis C treatment in the waiting list. And I want you, Silvia, to ask if you have registered this impact in the waiting list, because I think your waiting list, if we apart the COVID period, is always increasing, but our list has almost collapsed.
increasing. Yes.
Yes, I didn't show you this data, but we know that in a first period, HCV decreased, then increased again, but respect to the beginning, the indication is decreased also in Italy.
But still is 3 times higher than in Spain, 3 times higher.
Yes,
So maybe this is something that we need to address. I invite you all to move to the second block, because we will be addressing this topic, if you agree. So we're going to talk precisely about this, expanded indications, because we know the policy about hepatitis C has been very similar in Italy and Spain about the eradication of HCV infection. So this has forced the two countries, in cooperation between the authorities and the transplant centers, to expand the criteria. And let's see what difference occur between the two countries. So Magdalena, the floor is yours to introduce the next speaker to talk about expanded indications for liver transplantation. Thank you.
Now is the time for Jordi Colmenero. Jordi is a pathologist in the liver unit in the clinic Barcelona. He's the head of the liver unit, and he will explain the condition in Spain and the criteria for expanding donors and recipients. He participates in the consensus of the National Society of Liver Transplantation in order to increase the waiting list. Please, Jordi, when you want.
Yes, thank you very much for the invitation. Thank you very much for this meeting. Do you see my presentation now?
Yes, we can see it.
Okay, thank you. So the goal in the following 10 minutes is just to make a summary of what we are doing here in Spain. Just a summary. I know that in Italy you do pretty much the same, but we are very strict to adhere to this criteria for those patients that are enrolled in a liver transplant program. All the patients need to have 1 year expected survival without liver transplantation, less than 90%. This is very similar to other guidelines. We also have this criteria of avoiding futility defined as an expected 5-year survival with liver transplantation less than 50%. So those patients, all the patients that undergo liver transplantations in all the liver transplant programs need to reach that minimum of 50% at 5 years. And this is something that may change in the future. And we also, in Spain, I think that the majority of systems regarding the prioritization on the waiting list are very focused on the lifespan of the patients and the predicted mortality of the patients on the waiting list rather than on the quality of life. And we have used this social and utility and equity and distributive justice criteria. And we noticed several years ago that maybe the numbers, this mismatch in the number of recipients and donors was not that high because we were using techniques to get new donors. You know that in Spain, as Gloria showed, the number of patients of donors that were harvested by DCD started to increase in 2015. I think that we were very were innovative doing that in some centers and some areas like Catalonia. We now have more than 50% of the liver donors that are DCD. So we were very active on that, and we observed that there was a decline, as Gloria said, in the number of patients on the waiting list, and there was not an increase in the number of liver transplantations. And then in 2019, in the Spanish Society of Liver Transplant, we decided that we should do some changes and some meeting to expand the indications in liver transplantation. And the reason for doing that is that we are very active. We've been very active for a long time in liver transplant and harvesting donors, but we've been pretty conservative also in the indications. And we were, I think, most of the centers, in this meeting, we noticed that there was at that time, 6 years ago, some reluctance and some concerns from many centers to include patients with alcoholic hepatitis, despite the indication was established or almost established 10 years before with the paper by Mathurin in New England. We had concerns on transplanting patients severely in the ICU with ACLF type 3. We noticed in that meeting that in contrast to that, the people, all the transplant programs were willing to introduce the transplant oncology, especially the hepatocellular carcinoma, beyond the Milan criteria, but also for other liver tumors. And that was very variable depending on the centers. And all the centers, I think, that agreed that the 70 years limit for liver transplant was not appropriate, despite many centers were still doing that. So we did that meeting to reduce inequality between different areas and to stimulate the challenge to several centers that maybe transplant 30, 50 patients a year to be able to undergo, to perform liver transplants with these new indications. And the final consensus was that in Spain, the recipients' age limits was 75, and you recently showed, Silvia, in the presentation that you are transplanting maybe patients that are 76 or 77, things that we are not still doing in Spain. We established that alcoholic hepatitis, as clearly shown in many studies, is an indication, and those patients with one first episode of non-responder severe alcoholic hepatitis should be referred and evaluated for liver transplantations. We also encourage all the patients and all the physicians to refer patients with ACLF and to maintain those patients and to evaluate those patients on the ICU to perform a liver transplant. We also expanded the criteria of liver transplantations because there was some heterogeneity in different regions in Spain, so we set different limits. We set like an up to 8 limits or up to 7 without downstaging. And we also established that the hilar cholangiocarcinoma, despite there were few cases, using the Mayo Clinic criteria, was also an established indication of liver transplantation that was not something experimental, that was an established indication. And we encourage also all the centers to participate in trials to transplant patients with intrahepatic cholangiocarcinoma. And until a couple of years ago, in the randomized control trials to perform liver transplantations for unresectable liver metastasis of colorectal cancer. And that happened in 2019. And what we observed in the following years, as Gloria shown, is that, in fact, the number of patients on the waiting list still dropped, but the number of new indications started to increase in 2020. And this picture has been shown also by Gloria. And you can see, depending from 2020 to 2024, the number of different indications in Spain has been adding patients in the different indications. The most common one has been those patients with age above 70 years old that were discarded for transplant in many centers, and they are 55% of the patients that are being registered and reported in the register of expanded indications, but also those patients with hepatocellular carcinoma beyond Milan represent like 1 in 4 patients with unexpanded indications. In total, in these 5 years, a total of 600 patients have been reported to undergo liver transplant with these so-called expanded indications. Obviously, we know that maybe there is some infra-reporting in the register, something that we are working on, and that maybe sometimes we have dual indications that are difficult to report. For instance, those patients with transplant oncology older than 70 years old. And this activity in Spain has not been completely uniform. I mean, there are some centers that have been very active. This is similar to what happened with the introduction of DCD. And in fact, 8 units in Spain, 8 out of 26, are in charge of 80% of the cases with expanded, these so-called expanded indications. And as Gloria showed, the number of these so-called expanded indications represent now like 13% of the total new inclusions on the waiting list and the total patients that undergo liver transplantation in Spain. And it looks like it's still growing. And I can show our personal experience. In 2021, we only had, including this experience, 1%, 2022, 8%, and then in 2023, we reached a plateau, and I think that around 22% of the patients that we currently undergo liver transplantations have this so-called expanded indication. And this is very similar to what happens here in Catalonia. We are in I'm showing you data of Catalonia, a region of 8 million people. As you can see, maybe the number of patients included with expanded criteria are maybe 20% or 18%, and most importantly, the few results on survival that we have for this cohort of patients, despite they are few, is very good and is comparable to other indications, and as it was expected from previous results. So in summary, with the increased access and the low mortality, we've shown that these expanded indications have adequate hard outcomes. I'm not telling on benchmarking of liver transplant, but raw 3-5 year survival. And the question that we have now with this situation, despite this expansion, is do we have still room for expansion? Maybe we have to refine and go further on the technical criteria for intrahepatic cancer, maybe we have to consider patients with hepatocellular carcinoma that are all comers. We have to keep in mind that the introduction of systemic therapy for patients with HCC has to be in the portfolio of many centers, and we have to get a consensus on that. We maybe need to change some criteria for the transplant oncology, the specific technical changes, and we also have to keep in mind that if we expand these indications, we need to also expand those indications with equitative survival adjusted access to other patients. So in Spain, there is a huge stigma for patients with alcohol use disorders, despite they are who show the best survival at 5 years. So this is something that we might take into account, that maybe we have to open the door for patients that have intermediate risk of alcohol relapse after transplantation. And obviously the maximum in this potential room for expansion is maybe to consider all other indications with individual survival benefit at 5 years, but with a 5-year survival less than 50%. This is something that we do not consider, but maybe in some subset of patients, as Humberto, I think that already said on for patients with transplant oncology, can be a potential room for utilization of extended donors. And that's all. Thank you very much, and especially thanks to Gloria for the information that she provided me.
Thank you very much, Jordi. Next speaker, please.
Yes,
Giuseppe.
Yes, the next speaker is Professor Umberto Cillo. Umberto is a full professor of surgery at the University of Padova, and is the responsible of the HBB surgery and liver transplant unit at the University of Padova. Is a center. Last year, Umberto reached the highest number of 145 liver transplants, which was the highest in the history of your center. And Umberto is also the incoming chair of VISOT, the European Society for Organ Transplantation. Umberto, the floor is yours. I will leave the counter on, let you know. Please, Umberto, thank you.
Thanks a lot, Giuseppe, for this kind presentation. It's always nice to have the possibility to exchange ideas and experiences. I will go relatively fast because I have a lot of slides to show. Please stop me, will be time. I hope you will see my slides. Before going to the granularity of what's happening in Italy, as far as the Italian extended allocation and indication is concerned, let me go in the deep of a couple of methodological issues. We have been stuck in the last, I would say, 15 years to a methodological consensus process. We organized a couple of consensuses back in 2012 and 13, and we end up with this American Journal of Transplantation in 2015 in order to, clarify which were the principles that are guiding, our, indication process and allocation process in Italy. Look at this, as already been presented by Silvia. You will see in the middle that we decide all together in Italy, all the stakeholders, that the benefit was at that time, and even more today, the best endpoint for this, for investing the donor resources. And for benefit, I intend, for example, for hepatocellular carcinoma, those hepatocellular carcinoma that do not have any alternative therapy. So in a way, the BCLC-B responding to downstaging are very good included in this area. This is key in comparison with the Spain experience, I think. And on the contrary, you see on the right side, we want to limit as much as we can the pure utility. For example, again, hepatocellular carcinoma within Milan criteria with potential for alternative therapies, or T1, T, very early hepatocellular carcinoma. This is a distinction, I think, between the two countries. And also in the future, we want to limit, if it is possible, the urgent situation to adopting, policies that are producing a kind of preemptive approach to transplantation. But interesting enough, 10 years ago, also we decided to invest 5% of every single year donor availability in future benefit in new innovative indication. This is something that is really embedded in our community. So at the end of the day, we decided that we have, independently from mandatory criteria for selecting patients, we don't have mandatory, for example, criteria for hepatocellular carcinoma in Italy. Every center decided by themselves, but they are committed to achieve at least 60% survival at 5 years in any kind of indication. So using predictors which are useful for that. And the lower threshold has been, fixed MELD 15 and hepatocellular carcinoma T2. So again, the T2 in well-conditioned, in well-compensated liver is supposed to undergo resection or ablation much more than liver transplantation. Just to give you an idea that we don't have Italian criteria, Milan criteria not used in Italy in the last 15 years, I think. For example, this is a part of a protocol for hepatocellular carcinoma, which is important, I think. We use all comers philosophy with biomarkers selection, of course, functional radiology with the PET scan, and importantly enough, response to therapy and test of time. Just to give you an idea that we are a little bit advanced in this indication. So we retrieve and we recruit a lot of hepatocellular carcinoma patients. Let me go into the granularity, elderly patients first. How many patients more than 70 years old we transplanted in Italy? For example, in 2024, it reached 4.7%, which is pretty similar to the Spanish one. We have a relatively long experience in the last 3 to 5 years, and we were able to plot the overall 3-year survival, which is very much similar to the group of patients transplanted below 70 years, and this is also distributing the granularity between the different classes of age. Actually, the A class of age between 60 and 70 is the one performing worst, statistically significantly. Why? Because they don't have a good selection. What we are doing now in Italy is a very high and very complex selection process for patients over 70s. If you look at this, this is a part of our prospective protocol we are running the last 3 years. We have different level of analysis of patients above 70 years. And whenever you find more than 2 risk factors, for example, renal insufficiency and frailty or cardiovascular diseases and, obesity, the patient is excluded. So we include over 70 with a very high selection process. And to go further, these are our results in terms of patient survival. In Padova, 83% survival 2 years. This is a graft survival 78%, pretty much similar to the one transplanted below 70. This is a complication, comprehensive complication index, which is absolutely similar. Similar between the two populations is also the hospital stay and the ICU stay. Now let me go hepatocellular carcinoma. I think that what really makes the difference in the Italian expansion is hepatocellular carcinoma. Look at these figures. In the last 20 years, we have been seeing an increasing proportion of patients transplanted and waitlisted for hepatocellular carcinoma. Look at this, 50% of the patients are now listed for hepatocellular carcinoma in Italy, beside the gap of, the COVID. Let me give you a little bit of an idea of how we give priority and therefore value to the hepatocellular carcinoma in the waiting list. We have a first stratum of hepatocellular carcinoma. These patients have a downstage or a stable disease to a pressure of therapy pressure. Let's say BCLC-B, most of these patients are BCLC-B out of Milan criteria, which are responding to downstaging and stable disease while waiting. And this received the maximum priority. And this is the group of patients we are pushing a lot in Italy. You will see the figure now. The second group is the stratum 2, where they have a classic indication, Milan-in, or the peculiar criteria for transplantation in the different centers. And the last stratum, which is the one that is receiving the less priority possible, is T1 hepatocellular carcinoma, or the complete responders. They are allocated according to biochemical MELD. So they receive transplantation only if they have a decompensated liver. Look at this. So the stratum 1, the BCLC-B patients, in a way, account for basically 1,000 in the last 5 years, 1,000 liver transplantation out of 3,000, 1/3, 22% of the overall transplantation resource in the last 5 years. The stratum 1 also include 500 patients stable while waiting under pressure. So most relevant for selection processes, response to therapy and test of time in Italy, accounting for basically 50% of hepatocellular carcinoma indication. And the stratum 2 is the classical indication, let's say, traditional criteria for transplant. It's just a minimum, less than 500 are including patients with T1 or responding to therapy completely. Results 5 years, absolutely outstanding to my view, because we included, as you see, 50% of the patient, 1,500 patients out of Milan criteria, basically having a very good blue, let's say, close to 80% survival 5 years, which is outstanding. All the cases were above 75%, so above our standards. The stratum 1B stable on waiting list received more than 80% survival, and no difference between cirrhosis and hepatocellular carcinoma at the end of the day, 5 years post-transplantation. Now, going to non-ACC transplant oncology indication, we are in Italy pushing a lot. You see this trend, this loop of this curve. Number of figures are still low, but in the last year, we included 40 patients in non-hepatocellular carcinoma transplant oncology indication. Let me go for granularity. Overall, in the last 10 years, 100 patients were transplanted for colorectal liver cancer, metastatic to liver, and basically 7 for cholangiocarcinoma. Clustering is increasing, but more importantly, take a look to intrahepatic cholangiocarcinoma, because this is the area of major expansion together with colorectal liver metastasis in the future. Starting from colorectal cancer and metastatic, we in Italy, how do we proceed? We accept the inclusion on the waiting list, provided that the patient enter in one of the 5 shared common national protocols, which are prospective protocols for colorectal liver metastasis. I won't go into the details of the selection process. You have every possibility here. When the patient is a potential candidate, is discussed in a national group that approves or not the inclusion of the patient within one of these 5 protocols. And in the end of the day, the results. Look, these are the results on colorectal liver metastasis patients, 5-year survival, but overall cases, not only the 5 prospective trials that I show you now, but the overall Italian series, we had 62% survival 5 years, but we are expecting much more from the prospective trials, as you will see in a second. Let me go a little bit into the detail of one of the the 2 Padova protocols, the methodic one. The inclusion criteria are, again, response to therapy, stable disease, test of time, and biomarkers below 100, CEA below 100. 40 cases done so far, many centers in Italy, 3 years survival of 80.1%, which is a lot, I think, even though the disease-free survival is very low, as expected, like in Transmet trial, because most of these patients relapse to the lung, but this is not impacting survival, and we can elaborate on this. But most importantly, when we compare intention to treat these 40 patients with those treated with chemotherapy, propensity score matched, as in this slide, the benefit is massive, as you can see, even at a relatively early follow-up. This is the protocol that we're running, and I know that some Spanish centers are interested in this. Is auxiliary liver transplantation using only segment 2 and 3 from a living donation or from a split above 50 years of age. Why? In patients with unresectable colorectal liver metastasis, but with already lung metastasis or lymph node metastasis expanding massively the indication once resected, of course, provided the fact that this donor resource is coming from a living donation or a split above 50 years of age. Very early experience, and I will go fast, available for any question. Intrahepatic cholangiocarcinoma, super interesting. We have a prospective national the prospective trial, which is starting from Padova. The patient are undergoing gemcitabine, cisplatin, and durvalumab. Then, if stable disease or partial response, they can be inserted in the waiting list and stable for 6 months, and progressing to liver transplantation. And this is again is very interesting. Why? Because we have 80% response to Gencis Durva according to previous study. We already enrolled 22 cases, mainly in Padua, 15 in Padua, but again, we are seeing a fantastic 100% survival 1 or 2 years after the initiation of this trial, with very low profile of recurrences. This, of course, very preliminary. We cannot say anything on that, but the interest is really very high in this. And this is very high like cholangiocarcinoma, same implant as a design, same national protocol. Again, this is a National Center for Transplantation protocol, starting from Padua, but diffused on the overall country. We are really starting recruiting. These are the Claskin results of the overall experience in the last 10 to 15 years, which is dismal, I think. 50% is not enough, 5 years survival. But I think that with Gencis and Durva neoadjuvant approach, we're going to have much better result in the future. Couple of, I know I'm running out of time, but just a couple of slides on acute on chronic, just to tell you that we had last year a consensus, National Center for Transplantation, Italian Society of Organ Transplantation, and NICE for ACLF. We now have futile description, uncontrolled infection, severe respiratory failure, refractory shock, lactates, TAM, and SALT scores. And we are among the intermediate countries as far as, the commitment to involve liver transplantation for acute chronic liver disease. Of course, Germany and France are pushing a lot, Spain a little bit less. We are in the direction to promote this indication. Why? Because it has been shown that high listing centers are the ones that have better performance on the overall, community of acute and chronic liver failure. 2 slides on acute alcoholic hepatitis, very difficult indication, very initial experience in Italy, reported by Germany in this American Journal of Transplantation. Absolutely phenomenal results, as it was mentioned by Jordi, 100% survival post-transplantation. But what is interesting, very preliminary result, 1 patient out of 7 have a relapse in terms of alcohol abuse. But of course, this is an open issue to discuss. Just 3 take-home messages from here that we had, and we are pretty proud of this, a very methodologically robust approach to patient selection and expansion indication, going back to, let's say, 15 years at least. Consensus-based, blended principle system, pushing on benefit much more than utility, regularly scheduled readjustment, because we create moments to readjust the allocation system and the indication, and national share decision and protocols. There is no imposed national criteria for patient selection, with particular effort for hepatocellular carcinoma. Milan criteria are not anymore the standard in the last 15 to 20 years, I think, in Italy. Maybe because, of an internal competition, that's maybe an interpretation. And 5% of the overall donor resources dedicated to innovative indication, which I think is a strong decision-making process in the last 10 years. I stop here. I'm totally available for any question.
Thank you, Umberto. Thank you, Umberto, and thank you, Jordi, for your presentations. And Beatrice, we can open to questions. I see there is also a question from Ernesto Hidalgo.
Yes, there is one question, but I think it goes for the previous block. But let's take it, and then we'll go into the indications. So Ernesto Hidalgo places this question to the Italian colleagues, back to the rapid technique and split. Oops, sorry. How are you planning to allocate the left lateral sector? I don't know whether Silvia or Umberto wants to take over that question.
Umberto, Umberto, can you also please switch off the sharing?
Which I don't know how to do, but I will try. If you can do it from your side, it's going to be much better.
Maybe Amparo, you can take the presenter mode from Umberto. Yeah. That's correct. So let's do it that way. Umberto, please go ahead.
No, for the rapid technique, the nice part of it is that you need really no more than 200 liver cc for liver as a donation, because you do an auxiliary and then you promote in 15 days the regeneration of the liver. So the donor resources will be living donation, which is going to be very easy in a setting like Italy, where living donation is absolutely not accepted because they don't want to put in jeopardize their relatives. So when you ask for just 200 cc of liver, they say yes in 4, 5 for each family. So there is a huge amount of potential donor resource there, and split liver above 50 years of age, which are in a way out at this moment of the mandatory split liver rule in Italy. For the allocation of these donor resources, colorectal liver metastasis is the best way to go, according to the prospective trial that we are proposing, which is open to international centers. And as I said, I received already interest from some Spanish centers for this particular protocol.
Thank you, Umberto. We also have another question which is related to the expanded indications. And to me, I mean, I've been very astonished with all the data that you have presented from the Italian activity, but particularly, as stressed before, with donor utilization, which is pretty linked to your waiting list as well. So we used to be considering donors over 80 and much more expanded donor indications when our waiting list was larger. But right now it's 1/3 the one you described in Italy. Now, if I got you right, Umberto, you said that the number of recipients over 70 years seems to be very similar between the two countries. And Dr. Crespo, again, thank you for participating, Gonzalo. He asked whether we should start being less strict with selecting recipients over 70 years, considering that, according to what you saw, they are doing pretty well. So maybe we are more strict than we should. What is the opinion from both Jordi and Umberto?
Yeah, if I may start, I think that you have, and you are now utilizing more organs for 70 years and older. You have 6.6, I just noted, 6% of greater than 70. We have 4.7. The critical issue here, how you select. Our selection process for 70 years and older is absolutely super strict. So again, whenever you have 2 risk factors, the patient is out from the inclusion on the waiting list. That's the reason why they perform, in some instances, even better than the group of 60, 70 years old. And this is one point. As far as the indication, if I may, I think that the major issue is the strict adoption of Milan criteria in Spain, which is limiting a lot the number of cellular carcinoma which are included in the waiting list. We have, as we said, 1,500 cellular carcinoma included out of Milan criteria in the last 5 years, which is a huge amount of potential waitlist patients. And I think there is big space to open, big room to open in that direction.
Thank you, Umberto. Jordi, do you want to comment about recipients over 70? Otherwise,
yes.
Yeah.
Yes, I think that, I mean, that the in age itself is a bad marker of the outcome of the patient. We all know that, but certainly above 70, all the centers are trying to discriminate between this huge amount of potential recipients who are in shape to undergo a liver transplant. And I think that we all get the comorbidities, the surgical complexity, and the frailty as the 3 main areas we look at. And the problem is that the comorbidities and the cardiac comorbidities, now with adequate treatment, they perform very well. Frailty, we are not able to assess frailty super well in many patients. I mean, for those that are hospitalized, not who are at home, and the liver frailty index and the 6-minute walking test is very good. But for those patients that were in shape and have been for like 1 month in the hospital and they deteriorated a lot in 3 weeks, we are not sure who we need to get into transplant or to discard, because in this acute setting, the frailty, we don't know very much. So I think that there is still, as Gonzalo said, room for improvement, and maybe you have very good results in those patients. So that means that probably you can open the gates a little bit for those patients. That was this is what we think and what we plan to do in the future.
But we don't want too much, Jordi, because these are low benefit patients. If compared to the 40 years old with the cancer, we may achieve much better long span, quality adjusted life year gain. So that's you need to decide within yourself which is your best endpoint. And I think expand is okay for 70, but I prefer to expand to young guys with oncologic potentially radical opportunities. That's my perception.
Yeah. I think that one thing that is under the discussion in all this expansion is that what is the benchmark for survival in liver transplant? Is it 3 years? Is it 5 years? Is it 8 years? Is it also quality of life? So this is a discussion that is sometimes difficult because it depends on the age and the situation.
Yeah, 10 years is we publish on hepatology that, and the horizon is supposed to be 10 years because it's balancing the urgency with the utility, getting the better benefit. So that is very fascinating area of discussion as well.
I think Madalena has a question. So Madalena,
yes,
go ahead.
Thank you, Jordi. Thank you. I would like to ask a question or a comment for all. Do you think and linking to the previous block, should graph quality be defined in absolute terms, or could be related to the expansion of criteria? I mean, we discussed some graphs in relation to the short list. If we expand the list, do you think the percentage of discard organ will be decreased? It's obvious.
Humberto, go ahead, Humberto.
Or the matching, we will have a different matching in relation to the expansion criteria and the marginal donor.
Magdalena, this is a crucial point. I totally agree with you, basically. If you have in your waiting list, let's say, just an example, 10 patients out of Milan criteria, which are just responding to downstaging, so you perfectly know that your therapeutic window is so tight. So you have 1 month and a half in order to get the therapeutic window and transplant this patient, then you are much more prone to accept any kind of liver at the end of the day. And proportionally, you get more and more confident to accept, to test, and to see that with the machine perfusion, everything is basically working super fine. And this has been a positive, circle. So having push in the waiting list from the oncologic point of view gives you the strength and the courage to test livers that in another setting you would say, okay, I don't go for it. And this is very psychologically positive for the donors, for the surgeons, but also positive for the management of the overall donor resources, as you've seen in Italy.
Okay, thank you, Humberto. Gonzalo Crespo make a question, a comment, and he agreed with Jordi that alcohol-related indication can be increased as these patients usually do well after liver transplantation, considering a good addiction medicine follow-up is performed. I don't know if it's the case of all the liver units here in Spain at least. Stigma probably plays a role in the relatively low impact of alcoholic liver-related disease in the increase of indication. The question is, how can we track this? I hope this kind of conference help increase awareness. This is from Gonzalo.
So that's Humberto or Jordi want to react on that? I think Jordi already stressed that element, right?
I think that there's still many patients that can undergo safely liver transplant with good outcomes. And I think that sometimes we don't know who are they, and sometimes we have some reluctance to some particular indications. I know that the surgeons are very prone to undergo any type of surgical procedure because this is challenging. I mean, they are surgeons, and that we need them to do that. That is what we expect from you. But we also have room for improvement. You know, the non-surgical team. We need to expand this pool of patients because they can do well. And I don't know if 60% at 5 years, but I mean, I think that they can do well, and we can improve the survival in these patients. And alcohol is a very, 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 very good tool.
If I can add just a note, I think the switch as far as the alcoholic patient came when we changed the 6 months rule from the social environment rule. So that psychologically puts you in a different condition, you know, that you evaluate the person, the setting, the relationship, and the stigma is fading out a little bit whenever you don't consider just a tight cutoff, which is rigid and, you know, archaic, and you consider much more in a multidisciplinary setting, which is the, you know, the social setting and the social affordability and credibility on that particular patient.
Okay, thank you.
That's perfect. Well, I think in the interest of time, we should be moving to the third block. Thank you so much because I really believe this is an area where we can really change the game for the future. So thank you so much for two very outstanding presentations. So now we move to the third block about ex vivo perfusion, and I leave the floor to Magdalena to present the first speaker. Thank you.
Okay. Thank you, Beatriz. The next speaker the first speaker in Spanish is Dr. Bachiller. He is a clinical surgeon here in the hospital, the head of the program of ex vivo perfusion.
Hello, everyone, and thank you for inviting me to these excellent presentations. Yes.
Excuse me, Luis, can you mute yourselves, all of you, except for Luis, of course, because otherwise there is a lot of echo. So thank you.
Now can you hear me? With
yes,
good quality?
Better, and we can see your screen. Perfect. Thank you, Luis.
Okay, thank you. With this presentation, we can see the role that machine perfusions can have aiding us with all the questions we've been discussing. We will address the need for machine perfusion, its modalities, the current status and future perspectives in our country, and the role that assessment and recovery centers could play in this setting. These data have already been discussed, the growing role of the expanded criteria donors and the growing importance of the DCD donors in our country, and the high discard rates. This is especially important in my region, in Madrid. We have 4 transplant centers, and between them all, we have above 50% rejection rates of all the offers received. And if we look at the causes for rejection, we can see that there's quite a number of donors that could be used if we pushed forward our risk assessments, and the machine perfusion, the ex vivo machine perfusion, could help us with that. We can address the hypothermic machine perfusion, the HOPE technology, and we start by the evidence available. Hypothermic machine perfusion has shown to have an important benefit in ischemic cholangiopathy in the DCD donor setting with ultra-fast retrieval. The randomized control trial from Professor Porte in the Netherlands showed clearly this benefit but in the setting of DCD with NRP retrieval, the benefit is not so clear and hasn't been demonstrated so clearly. And this work from the group of Dr. Dukowski and Dr. Schlegel in Switzerland, in the setting of DBD donors, they showed less severe complications and less graft loss. There's not so clear a benefit, but still a benefit in this subset. With this in mind, we performed a brief survey for this seminar in the Spanish groups, because we don't have official data for the usage of the HOPE technology. We have responses from 18 out of 26 groups, and 2/3 of them are using hypothermic machine perfusion. The indications are expanded criteria donors, and the majority of them use them for logistical and or schedule reasons. The prevailing feeling is that it improves the quality of the donors, and a third of them has performed more than 40 cases. 1/3 of them have restrictions. It means 2/3 have free usage of the technology, and the main concerns or the main restrictions for usage is due to the price of the technology. The remaining groups that haven't started the hypothermic perfusion program are interested, all of them, in starting the usage. And the main impediment for starting the usage is related to the price, the personal usage, and logistic reasons. In our group, we did a study of our complications related to ischemic cholangiopathy, and we found that in the DCD setting, even with the usage of NRP, we have a very high rate of ischemic cholangiopathy. We have above 20% ischemic cholangiopathy. So in the years between the studies in the years 2018 to 2023. So after 2023, we started using hypothermic machine perfusion to all the DCD donors after retrieval, even with a previous NRP. And we don't have the definitive data, we're still pending, but out of 19 cases with 6 or more months of follow-up, we haven't observed one single case of ischemic cholangiopathy, so the results are quite promising. As for normothermic machine perfusion, what we do is we restart the liver. So this allows us to evaluate what's happening to the liver. We can evaluate the consistency, the macroscopic aspect, the metabolism, and the bile and production and characteristics. But it imposes a huge logistical challenge for the team. It quite prolongs the procedure of the transplant, and it needs an extra personnel to care for the machine and evaluate the results. The evidence we have is quite strong. The COPE randomized control trial from the Consortium for Organ Preservation demonstrated quite a decrease in early allograft dysfunction, but the main outcome, in my opinion, is that the rejection rate dropped to a half in the subgroup of normothermic machine perfusion. So we improve the usage of the donor pool. And another key article regarding normothermic machine perfusion is the VITAL study, in which the UK groups connected 31 previously discarded livers. These were livers that were discarded by all the UK groups, to the machine perfusion, and they were able to transplant 22 out of them with good results. So we can see that if we have high-risk donors with the usage of normothermic machine perfusion, we are able to be bolder in the acceptance of the livers. I'm sorry. So this is a brief resume of the roles of hypothermia and normothermia. These are a slide adapted from Professor Porte, and I think it quite illustrates the utility of this technology. Hypothermia is a simple and cheap procedure that produces an enhanced preservation. We can use it for extended criteria donors, and we improve the results. And normothermic machine perfusion is a costly and more complicated procedure that can help us assess and recover high-risk organs and push forward the yield of the donor pool. If we come back to our local data in Madrid, out of all the livers discarded, if we assume we can recover between 50 or 70% of the high-risk organ, that would mean a 25 increase in the activity of all the 4 groups in the region. So with this in mind, we started the project of a centralized recovery center in order to maximize the cost and the personal resources involved in this technology. With the support of the local authorities and the National Transplant Organization, we proposed the creation of an assessment and recovery center in a back-to-base strategy in which the retrieval team for the allocated center for the donor would evaluate the validity, and every non-valid organ would be offered the connection to the machine perfusion, to the normothermic machine perfusion for the definitive validity. And if it was valid, the organ would return to the allocated center to be transplanted. The center is located in our center in Hospital Gregorio Marañón, and it would provide service to the other 3 centers of the region. So far, we have done 28 perfusions, and we have successfully implanted 19 out of these 28, with very favorable complication rate and outcome. This poses a logistical challenge, it's clear, and this is a very brief example to illustrate that. This is a young donor with ischemic injury that were offered to the 12 de Octubre hospital, another hospital in the region, and they had a problem with their recipient, and it sadly passed away during the surgery, and they have to prepare another recipient, extending beyond the acceptable limits the ischemia time. So they called us, they brought the liver to our center, we connected it to the machine, and when it fulfilled the validation criteria, we proceeded to transport it to their center. Here you can see all the logistical challenges involved. We need sanitary transport capable of transporting a functioning machine. The transport should be done in very stable conditions, so we required police escort to arrive to the other center, and we were able to successfully transplant the liver. So, in conclusion, we can say that ex vivo liver perfusion can improve our results from extended criteria donors. Hypothermia is simple and universally applicable, so we can say that we can improve the preservation at low cost, and the normothermic perfusion will allow us a functional evaluation, and we can improve the donor pool. But we have to address the logistical challenge, so the creation of centralized recovery centers, I think it's a must if we want to expand this technology. And thank you very much for your attention.
Thank you, Luis. So I think we can proceed to the next speaker. The next speaker is Davide Ghinolfi. He is the head of the liver transplant surgery of the University of Pisa, a center performing around 150 liver transplantations per year, and who has performed in the last 5-6 years over 100 procedures with machine perfusion. Davide has a great interest in the field of machine perfusion in Italy from a clinical and a scientific point of view, and so I leave the floor to Davide, also because Davide works in Tuscany, in the region Tuscany, where both DCD type 3, but mostly also DCD type 2 are used. And DCD type 2 are also a source of liver for transplantation. So, Davide, the floor is yours. Thank you. Davide, we don't hear you. Personally, I don't hear you.
Okay. Now, can you hear me?
It's okay. It's okay. Please go.
Thank you, Dr. Fortrina and to Dionte for this great opportunity and to share our practice, which is based on the experience we have accumulated over years. At the beginning, when we started with machine perfusion in 2016, it was pretty simple. You were doing hypothermic perfusion or normothermic perfusion. But now the organ preservation techniques have multiple possible combinations, and each technique has different advantages, potentialities, and target organs. So I think that when we arrive at the point to decide which temperature, which device, which protocol we have to apply for that specific organ, each center should identify some strategies able to minimize the damage, provide graft conditioning, perform organ viability assessment, or optimize logistics. In 2 words, we have to increase the number of available grafts, especially when we are considering DCD grafts or extended criteria DBD, meaning steatotic of all the liver, and to promote safety for the recipient we want to transplant. So moving from DCD, we have to admit that the landscape of DCD donation is quite heterogeneous. There is no general consensus on the standard definition of warm ischemia time, even if we know that a prolonged warm ischemia time leads to biliary complication and graft failure. In Italy, based on our legal framework, we are willing to accept a longer no-touch techniques to 20 minutes and not counting, considering functional warm ischemia time when the systolic partial blood drop below 50 or the saturation below 75%. So over the years, in order to make possible what we believe it was impossible, we immediately set up a system based on 2 machine perfusion, normothermic regional perfusion, sequentially followed by ex situ perfusion. The first mainly for graft viability assessment, and the second one for a further graft protection. But even when we are considering which are our NRP viability criteria, which are also named Italian or Milan NRP viability criteria, in our country, we are willing to accept higher level of lactates or transaminases. And our acceptable criteria are way in excess of those that are generally used in other European countries. So the open question is if you are doing the right things, meaning if the sequential NRP plus machine perfusion is the right way to go, and if you are moving inside correct NRP viability criteria. So what the literature told us is that those countries who routinely apply sequential NRP and machine perfusion are able to reach 2 goals. The first one is to increment and to have the highest liver utilization rate, And the second one is that generally we have the best results in terms of long-term graft survival. But even if we compare the sequential approach to the use of the ex vivo machine perfusion, in particular of hypothermic machine perfusion, we see that the sequential approach is able to minimize the complication. Basically, over years, we have zeroed the graft loss due to ischemic cholangiopathy. And in general, the incidence of biliary complication and ischemic cholangiopathy has been reduced several times. So the next question would be, what can we do next? How can we further push in the limit in DCD donation? Well, if I have to think on in this field, I have to come back to our preliminary experience when we started with uncontrolled DCD, and we were analyzing those grafts using NRP followed by normothermic machine perfusion. At that time, the discard rate was pretty high at about 80%. But what we saw is that if the NRP was within the Italian NRP viability criteria, it was almost impossible to discard the graft on the following re-evaluation on normothermic machine perfusion. So if we come to what I call the worst case scenario, the Italian uncontrolled DCD, definitely we know a lot of things. Of course, they perform worse. The graft survival in uncontrolled DCD in our full series was much lower than the controlled DCD. But we saw that we are not losing the graft because of biliary complication of ischemic cholangiopathy, but we lose the graft in the first months after liver transplantation, generally because of primary non-function or severe early allograft dysfunction. So when we reanalyze our data, we saw that there are some factors before liver transplantation that are strictly correlated to the graft loss. And when we analyze the data during NRP, we saw that the lactate and transaminases are much more important, but there are also some recipient factors. So we can say that if we use graft control or uncontrolled, which show a drop on the lactate within the first 120 minutes during NRP, let's say a drop of 20%, we are in a good environment and we can safely use those grafts. But if we want to push the limits, well, donor recipient matched with a recipient with a low BMI without previous abdominal surgery is a definitely important things to improve our results. And the other question is, after NRP, which kind of machine perfusion should we use, hypothermic or normothermic perfusion? Well, I think there is only one way to discover these things, is based on the use of prospectively randomized trials. So that's what we have done in PISA with this paper that is going to be published. We selected 50 DCD. The grafts were selected during NRP based on our NRP viability criteria, and then the grafts were randomized to hypo or normothermic perfusion. The machine were not used for further evaluation. And we had an interesting results that based on the machine and the temperature that you use, you have different profile of complication. Our graft preserved in hypothermic machine perfusion were varied by early dysfunction or primary dysfunction of the graft, but without any biliary complication, while in the NMP group, we suffer of a higher rate of biliary complications. And this is in line with the literature that we can find on PubMed, where hypothermic machine perfusion is granted of being able to reduce biliary complication, and in particular ischemic cholangiopathy, while the data are quite questionable for normothermic machine perfusion. But what we can do next? What we can do if the data during our NRP are questionable? Well, I think the only way is to reevaluate the graft under normothermic perfusion. Here are our acceptance criteria, which are mainly based on the downward lactate trend, stable flows, and we do not evaluate the bile production unless the transaminases are very high. And here comes the problem. We have to sincerely ask us if we really trust to absolute viability criteria. as long as you want to push an organ accepted, viability criteria is all about risk stratification, because there are no viability criteria able to guarantee you success. It depends on the organ you are working on, the machine perfusion technique, the recipient you are transplanting, or if you are doing intervention related to the graft. So we like a lot the Netherlands approach, dividing the graft on green, orange, or red zone based on the data on the hepatocyte or cholangiocyte parameters evaluations. And if we moved on the older donor, this conclusion comes to our experience on the older donor. The median age in the Pisa and in Tuscany is pretty high. This year was around 74 years old. And we had several problems of ischemic cholangiopathy. So we were thinking in 2016 that NMP could have been help us in protecting the graft. At that time, there were no viability criteria. But what we done, it was to perform and preserve organ already accepted for transplantation. And when we look back at our data and matched the data we had during machine perfusion with Birmingham, Cambridge, or Groningen criteria, we saw that we should have not transplanted up to 70% of the graft. And that here comes our viability criteria that are mainly based only on the downtrend of the lactate. And the other important thing is that each criteria you want to apply has to be matched with the organ quality and the recipient you want to transplant. For older donor, we move to a hope of preservation, and I think this is a right way to increase the platea or liver transplant recipient. I want to show a very simple case. This was one of the first cases we have performed after systemic treatment of a bilobar HCC. This is a 60 years old patient, has about 10 HCC nodule. The largest was 5 centimeters. Was a low MEL patient. After atezolizumab treatment, he got a nice liver. He was transplanted. The liver was preserved with hope, and the patient was discharged after 6 days. This is nothing special unless you know that the liver graft was older than 100 years old, and this patient now is more than 3 years after the transfer, is alive, in well condition, and free of disease. The bad question comes if you want to use hypothermic machine perfusion for improved logistics of very old donor. I think you can prolong perfusion and preservation for a limited amount of hours, no more than 10 to 12 or to 14 hours. And here comes to the last point, is the use of steatotic liver grafts. We regularly use liver grafts up to 30% of macrostatosis, but the problems come when you want to push harder. Technically, I think the ischemia-free organ transplantation would be the best way to use this graft, but it is technically and logistic demanding. And many liver transplant centers adopt NMP for steatotic graft. This is an experience of Milan and Turin, where they evaluated 14 liver grafts with a macrostatosis more than 30%. 10 have been transplanted, but anyway, they have 40% of primary non-factor. This is an experience of the Mayo Clinic with over 300 liver transplants. The results were much better with the use of normothermic machine perfusion, and they could show an improvement of 3 years graft survival from 89 to 72% at 3 years with the use of NMP, and also a reduced incidence of cardiac arrest, post-perfusion syndrome, and biliary complication, but with 2 characteristics. First, NMP should be used in an upfront way in order to limit the ischemic time. And second, the preservation in machine perfusion should be extremely longer, more than 10 hours, which is quite different what we are doing in our regular practice. Finally, and this is the way we are doing now, you could also use a not so-called hypothermic perfusion, mutuating some evidence from the lung transplantation to liver transplantation, because this kind of preservation may provide a reduction in the inflammatory environment and superior physiological function. I want to conclude telling that Machine perfusion may be used for expanding the liver pool in any other way, and Umberto is a specialist in this. You can use it for performing split liver transplantation to enlarge your pediatric transplant program, or for rapid or for oncological reasons, but logistic and mutual knowledge between equipos is the key. And finally, and that is what we are working now, there is a relationship between the inflammatory response during machine perfusion and outcome. What we have demonstrated is that different donor types show specific cytokine profile, and there is a correlation between the cytokine signature and the outcomes after liver transplantation. So I think that the integration of clinical and perfusion parameter and perfusate maker will be very important in the future to assess graft viability. These are my conclusions on the sequential use of NRP and machine perfusion in DCD liver transplantation, variable graft, and steatotic graft. I thank you very much for your time, and I'm ready to get any question if there are some. Thank you.
Thank you, Davide. Beatrice, before I leave to all the questions that you have, I want just to inform that since last year, we will have a financing coming from the Ministry of Health of 10 million euros per year in order to support all the centers to buy machine perfusion devices. Of course, it's a sort of partial reimbursement, but it's an important support to all the centers to use the perfusion devices. Davide, can you switch off the sharing? And then I leave, and then I'm okay.
Thank you, Giuseppe. You just put me under a huge pressure to get machine perfusion devices for everyone in the country. Okay, so thank you so much to both speakers. If you can stop sharing your screen, Davide,
la presentazione.
or maybe Amparo, can you take the presenter mode? Thank you. That's perfect. Okay, so we have a question from Dr. Manuel Porras. He asked whether is there any place for combination of hypothermia and normothermia in a normothermia in a potential donor? And I guess the two speakers can address this question, both Davide and Luis. Who wants to jump in first?
I don't see Davide.
No?
No.
I cannot see him either. Hopefully he will enter back into the room. Otherwise, Luis, the question goes.
We call him.
I think Davide addressed perfectly the combination between NRP and machine perfusion, whether it's hypothermia or normothermia. But the combination of hypothermia and followed by normothermia maybe should follow an algorithm between for the users of very high risk donors. The group from Switzerland, from Professor Dukowski, proposed the usage of flavin mononucleotide as a risk marker in hypothermia for a stratification of the risk of the grafts. And maybe if we could all use this method to assess the risk. The problem with flavin mononucleotide is a very cumbersome method, and it's very variable, and it has to be validated locally with each group, and that's the difficulty in using that. But if we could all use the risk stratification with these markers, maybe with the inflammatory markers Professor Ginolfi was alluding, we could connect the high risk livers after hypothermia to the normothermic machine perfusion for a final assessment. Other protocols may include the controlled rewarming that's advocated by the Netherlands group from Professor Porte, and they think in an experimental setting, they have found in an experimental setting that it could be a factor protecting especially the high steatotic livers. A controlled rewarming from hypothermia, a progressive rewarming to normothermia may protect the highly steatotic livers from the ischemia reperfusion injury.
Thank you, Luis. I just learned from Giuseppe that we lost Davide. He's connected through Giuseppe's phone, but I'm not very sure we can hear him. Maybe he can make a try. I don't know.
Yeah. Do you want to put a question to him and we can try to?
Yeah, well, we have another important question, which is regarding the organization of the regional organization of machine perfusion devices. We learned from Madrid that we have a regional hub there, but Madrid is a very particular region because we have several liver transplant centers within a 20-kilometer area. This is highlighted by Dr. Gonzalo Crespo again, who is very active on the chat. Thank you, Gonzalo. And he wants to pose the question about to Italy about the way you have organized this in terms of how many hubs, where to place them, because we have, you know, this situation in Barcelona or Madrid where different transplant centers are very close to one another, but then we have Andalusia, for example, with several centers, 5 centers, but very far away from each other. So how do you put some rationale to creating these centers that are going to be recovering livers for others? I don't know if Davide can answer through your phone, Giuseppe, but maybe you can answer yourself otherwise.
Davide, if you want to try, and then I add if needed. Davide, you can answer.
I mean, can you hear me? So I think the idea of recovery center is great, but that has to be answered in the context of the legal frame of each country. We have a regionalized system, so it's quite hard to see how we could do it. But definitely this is the future and this is the way to go. I think each large center, or actually for macro region, should have their own center to reevaluate organs. This is a matter of organization and resources, especially once the long-term perfusion, especially the long-term normothermic perfusion, will be implemented on a regular basis in all the countries or in several countries as well. But I think this is definitely the way to go for the future.
Thank you. I see Umberto and Jordi. Umberto?
No, very quickly. I think the issue is phenomenally fascinating for the future. We need to really think also at the national and at the societal level how to organize the future in this direction. The crucial issue is accountability. When you have an organ, who is taking care, who is responsible for results or failure, just in case. So there are some proposals from the companies that are pushing a lot in order to have their setting and the facilities in order to provide everything for mitigation or whatever kind of manipulation of organ is concerned. Other options are institutional, but the institutions do not have enough funding in many cases. I think that the best way to go is to create joints where the companies may provide financial support and technologies, and the institution respond for accountability. This is the best setting in my idea for the future, but we need to discuss it.
In any case, I would like to jump in to say that the situation in Spain is very similar. So we are very decentralized. We have the national authority, the regional authorities, and again, the regional authorities and the local administration is in charge of covering the resources and the finances. So we really need to make likely a similar approach to Italy, with the national authority giving support and establishing a common policy, and then the regions making somehow the regional, or addressing the regional aspects of this approach. Jordi wanted to
we have
We'll have Jordi with one question and then Giuseppe. Sorry, Giuseppe, Jordi.
Sorry, yeah, there is more question, comment. I mean, as you pointed out in your presentations, you know, the time from harvesting to start the ex vivo perfusion is, I think it's very important. It's a crucial point, and then this is a problem when we face this prioritization strategies for people, for patients from other regions, because we are all think very regionalized. So I think that one of the points is whether the machines get the approval for transportation, and as long as I know, only one machine is only able to do that. So this is only two. Humberto, I'm not very, but at least I thought that until very few months ago, there was the point. Something as simple as having a plug in an ambulance that may seem completely absurd. I mean, we didn't have that here in Catalonia, and we had to change all the contract with the ambulances just to make the possibility that one machine can transport an organ. And I think that as when the hypothermic machines are able to transport, and these capabilities are in different machines, I think that is going to change a lot the field of the organ transplantation and transportation and the exchange of organs with extended criteria.
Thank you. I think we have run out of time. I'm going to give the floor to Giuseppe, who wanted to speak, and you can also take the opportunity of saying some closing words, and then to Magdalena, and then we finish the webinar. So Giuseppe.
Very quickly, just to say that this centralized funding that we are going to give to the regions is very important on the fact that it is a way to stimulate the usage of machine perfusion on one side, but it's also an opportunity for us as national competent authorities. Think about that, Beatrice, to get the data. So we have a sort of registry where we get all the data of all the devices, like the Crystal registry that they have in France. And more the usage of devices in a very regulated context, and with the idea to see what is the real benefit of each device for each scenario is becoming more and more important also in the exchange of organs that we have within Europe. So it's a really strategic opportunity. Of course, speaking about the hubs, the ARC for the machine perfusion, it's something that is it's very hard to see how to put it in place just because of the regionalization of the health systems. And I want to thank you for this opportunity for hosting Italy in this webinar. Thank you.
Thank you, Giuseppe. Magdalena?
Thank you very much for the symposium, Beatriz. I'm very happy to participate here. And I have some reflection to make with the team in order to analyze the donation and the high rejection of graft here in Spain. I really don't understand the difference in Italy. And in respect to the ex vivo perfusion, the crucial or the nuclear point is the list or the waiting list. If we don't have a waiting list, we don't have the need to recover organs. So we have really to make an effort in order to expand criteria with rationality. And it's the homework for the Spanish team, I think, and the Spanish society with your team too. Okay.
Thank you. Well, I would like to thank all the speakers, and again, CNT, the Spanish Society of Liver Transplantation, Magdalena, Giuseppe, and of course Gloria for the organization of this event. I think it's been great to share the way we do things in the two countries. For us, we have things to learn from you. We have very high donation rates. It's true that with very difficult donors, but while 90% of our donors are kidney donors, it's outstanding to see that you have the same figure for livers, and so we need to carefully balance that. As Magdalena said, our worry, our great worry right now is the waiting list. So I have the question of whether all the patients who should make it on the waiting list are waitlisted. Even normal non-expanded indications. So we really need to think whether all patients are really getting the chance of receiving a liver transplant or not. And of course, we need to get ready for the future. Machine perfusion is something that is not seen as a great need right now, except for the surgeons, because we know you surgeons love the machines. But it is true that if we don't have that pressure on the waiting list, you don't have. I mean, you are not that powerful in trying to expand indications and in trying to push the limits, which is given, that opportunity is given by machine perfusion. So we need to see the two sides of the coin, the waiting list and the liver availability. And of course, looking into the future, machine perfusion is going to be there for many other things, not only for preserving the livers, but for treating the livers and for many other aspects that you will cover in your presentations. So again, thanks to all. We have work to do, and we look forward to a future symposium or maybe another opportunity to compare our systems, because it's always a learning opportunity. Thank you and have a beautiful day.